defined by the time course, the evolution of those symptoms, and then the risk factors, which risk factors that the patient have. I think apart from, so because we are talking of mouth deviation, I think that leads me to the facial nerve most commonly, and therefore I'll think about all pathologies that can cause facial nerve palsy. So commonly we think about stroke, but there are other things like Bell's palsy. But then we can also have other pathologies that lead to mouth deviation uh, uh, due to facial nerve palsy by itself, and of course I think that's a simplistic way of thinking about it, thinking about the facial nerve by itself, because the pathology can be anywhere. So I think there's a number of things that can cause that, not just stroke, which is the commonest thing we think about, and therefore I'll be interested to hear more about the history in order to see where that will lead.
Yeah, that's a pretty nice start. So, when you say that time frame will lead you to the different,
Joseph.
oh, yeah, very sorry, I was muted. Yeah, so I'm saying when you say time frame is the main thing that is leading you to consider some differential diagnosis in a case with the mouth deviation. Yes, you mentioned stroke, and so that would be like abrupt onset. Any other stuff that you we could think of, and their time frames probably.
Okay, uh, so apart from stroke, and just like I said, I mean, if you talk about mouth deviation, what it basically means, because normally we expect someone, because when we talk of, we have the muscles of facial expression, and these muscles are supplied by the facial nerve. So when we talk about mouth deviation, so we have the muscles in the lower face that are involved. So facial nerve palsy is one of the things that I'll commonly think about. Why? Because so just like when we talk about other things, like when you talk about, for example, if someone is having muscle weakness, I mean the pathologies are not always just in the motor neurons. The the problem could be in the muscle, but then if you talk about a primary muscle disease and think about muscles of facial expression, I think it's a very difficult thing to come up with differentials, and probably because I'm not a neurologist. Uh, Maybe if someone came with limb weakness, I would intend to think about throughout the neuraxis, from the CNS to the spinal cord, and then to the neuromuscular junction and the muscles themselves. But then when it comes to muscles of facial expression, I think a reflex is going to the facial nerve. But the thing would be that we have a problem in the brain. That is, if we have a supranuclear, lesion, or the problem could be in the facial nerve itself. So when you think about diseases of the neuromuscular junction, like myasthenia gravis, the things that you talk about are mostly, they will be symmetrical. So someone is having ptosis, for example, it will be most likely it will be symmetrical ptosis rather than on one side. So, but then when you talk about issues of the facial nerve, now the question that you asked, so we have that framework. When we talk of something hyperacute, we think of something vascular, and then something acute, we think about an immune mediated issue, infections. But we also have the time course can be subacute to chronic. We have some other things that we think about, including degenerative issues. Although, yes, again, with degenerative diseases of the nervous system, I cannot quickly think about anything that can cause, that can affect the facial nerve on one side. If at all we are talking about the facial nerve, that it affects the facial nerve on one side, it's not affected on the other side. But yes, you also have, you can have other things like like infections, for example. Uh, so these ones will be more acute to subacute rather than hyperacute, which we talk about in a vascular lesion. So that's why I'm interested in the time course.
Mm-hmm.
Although yes, I should say that with mouth deviation, or when I talk about the facial nerve, I think I'm much more inclined to think about a disease in the facial nerve itself, rather than in other structures like the neuromuscular junction of the muscle. Though I believe that is a deficiency on my side, and so it's important, I think, to go and read about diseases that involve the nerves, the facial nerve itself, in order to have more differentials. So I think at this point, I'm more likely thinking about strokes, thinking about Bell's palsy, although yes, you can have some viral infections. So for example, if you talk about something like zoster,
Mm-hmm.
I think something tells me that yes, those zoster can come with. We know there is herpes zoster oticus, but I think yes, zoster can also involve the facial nerve. So there is a number of things that I can think about that would explain this presentation apart from just the stroke.
Sure. Yeah, that's pretty impressive. So let's see the HPI. This patient told me 8 years ago she noticed her mouth was deviating to the left side when she was continuing her work. She was on job on that day, and but she recounts that 2 months prior to that incident, she had noticed twitching of the left eye that worsened as time went on. From the moment she noticed mouth deviation, twitching would start with the left eye and radiate to involve the lower left side of the face. These symptoms worsened when she had an empty stomach, when she had stress, anxiety, when she was tired, and would disappear when she was happy. Her daughter reports that twitching and mouth deviation persists during sleep, and so there is no involvement of the neck or limbs. There is no facial numbness, no inability to close the eye. There is no difficulties chewing or swallowing. There's no hoarse voice, no cognitive impairment, and no altered mentation.
Okay, so that's the HPI.
Yes.
Okay, can I see the yes first slide? So this is not a thing that started a few hours ago. So she first noticed this 8 years ago. Is that right?
Yeah.
And the mouth is deviated to the left side.
Yes.
Uh, and 2 months prior, she noted that twitching it's in the left eye
Yeah.
that worsened as time passed. Okay, and from the moment she noticed the mouth deviation, there's so twitching left eye, and then to also involve the lower left side of the face. And these symptoms, okay, I hear some funny associations there. So, for example, when she had an empty stomach, when she was stressed, when she had anxiety or was tired, and would disappear when she's happy, and they persist during sleep. Can I see the next slide? Okay, but otherwise, there is no involvement of the neck or limbs, and then these are the symptoms: no facial numbness, so the trigeminal nerve here is not involved, no inability to close the eye. So basically, the upper half of the face is not involved, and then difficulty with chewing. So chewing, it's the trigeminal nerve that is involved, the muscles of mastication. So the trigeminal nerve is not involved. But again, when we talk of swallowing, hoarseness of voice, we talk about the vagus nerve and the glossopharyngeal nerve, and then no cognitive impairment. So basically, uh, the cerebral hemispheres, or at least the hemispheres are not likely to be involved here, and then there is no augmentation, and that's it. Uh, many times when we discuss cases, actually, many times, and that's why it's crucial for clinicians to read a lot, and of course to learn from experiences, because many times expert clinicians make diagnosis by pattern recognition. So just from this short HPI, I know that I'll have a hard time getting the diagnosis right, because I do not recall, or I do not remember reading about something, symptoms uh, that are convincingly involving the facial nerve, maybe uh, that are aggravated by stress, aggravated by anxiety or hunger, but then relieved when someone is happy. I do not know yet. When I hear that, nothing crosses my mind. I think I'll just be patient here and wait to learn at the end. But then again, just like I do whenever I come across a complaint that is unfamiliar, or something that doesn't make sense, I try to think slowly. So I start from what I know, and then approach what I do not know, and see if I can get close to it. Uh, so for this particular patient, there are things which are not telling for me. So the patient is having mouth deviation to the left. So when someone is having mouth deviation to the left, what it means is that I would say yes, and that's the thing. So maybe this can help us make some progress, but this could mean that this patient is having weakness on the right, is having weakness, which means that the facial nerve on the right uh, is not working. So that is one way to think about it. But then coming to these other symptoms, so for example, when there is twitching, the twitching is on the left rather than the right. So you have some symptoms on that side, which at first you wouldn't tend to think that this patient is having weakness on the right, but then you have symptoms like I would say blepharospasm. So the patient is having blepharospasm on the left, and all the other symptoms that you are mentioning on the left. Can I see it again? Then the first slide of the HPI. Yeah, so twitching with the left eye and then radiate to involve the lower left side of the face. Yeah, so that makes me think that we have a problem. So the problem that we are talking about is actually on the left rather than on the right. So maybe this patient is not having right facial nerve palsy, but this patient is having a problem on the left side. And what is that problem? Uh, so this you would think about it as it's actually a problem. This could be a problem of the muscle rather than a problem of the nerve. So actually, I think it's time to activate movement disorders, including dystonia. So I think as much as I was thinking about Bell's palsy initially, what I am seeing here, and of course, you should remember that I'm discussing this from a point of inadequacy, meaning I do not know, I have no clue what is going on. So I'm just trying to think and theorize on what is going on. But what I see likely now is that probably I cannot completely throw out the idea that we are dealing with a nerve issue, a neuron issue. So I think I'll still keep the nerves close that probably are having facial nerve issues. But then the next thing that I need to think about is uh, movement disorders, due to lack of a better term, movement disorders. So Uh, dystonia is one of those, and especially, of course, when you are talking about the muscles of the face and the exoskeleton, we talk more about dystonia rather than these others like chorea, athetosis, and the others. So I think I should consider a hyperkinetic movement disorder here, especially dystonia. So that is one thing that I have. And then the next question I'll ask myself is that uh, can we have a nerve issue that leads to spasm of the muscles? You have an issue with the nerves, and then you have spasm of the muscles. So that's a question that I keep. And of course, I know that especially when you talk about the limbs, we know that of course if you have weakness, if you are dealing with an upper motor neuron lesion, you have spasticity. But is it the same case with this facial nerve? We do not seem to see paralysis of the left side of the face. All we see is what seems like paralysis of the right side. But I think at this point, I'm convinced that probably the right side is quite okay, but then it is the left side that is pulling, meaning we have spasm of the muscles on that side. So I think uh, that is what is more plausible to me at this point, because I do not have an idea of what is going on. So that is the theory that I'm entertaining. But then I believe other components of the history, I'll need to know about some medications, because when you are talking about movement disorders, uh, some medications can be involved, but also physical examination, I think, will help me clarify some issues. So other components of the history, Joseph.
Yeah, thank you very much. And yeah, everyone, this is called clinical reasoning. So this is it. I love it how David is dissecting this, and he's telling us he doesn't he doesn't know what's going on, but he is reasoning and trying to figure out which side has the problem. That's pretty impressive. I loved it. So let's move on. Um, so the view of the system was unremarkable. Yeah, so I should mention one thing. So from that moment, when she noticed mouth deviation and 8 years elapsed around here, it remained stable, like it was the same. There's no progression. And past medical history, she has hypertension and meds, so she denied to use the usual meds for hypertension. She was on herbal remedies for hypertension, like garlic and soy milk. And family and social history, she's married, she's retired. Her first degree relatives are in good health, and she doesn't drink or smoke. Is there anything there, David?
Okay, so I think I'll just spend a very short time here discussing about the history of hypertension. So um, if we are discussing, I think we'll probably uh, I wouldn't think that we are dealing with a stroke for 8 years. I mean, something that unless if we are talking about something that happened hyper acutely 8 years ago and then remained stable for all this time, then we will probably be talking about stroke. But then the history of hypertension and the connection with what is going on here, I cannot see a direct link. I cannot see a direct link, but I think I'll just stay open in order to be educated later on. But because with uh, hypertension, and then when you have complaints like these ones, we tend to link them with stroke most commonly. So what is going on with this patient, I'm not convinced, at least uh, 8 years later, that we are dealing with stroke. So I think apart from that, I think I do not see anything else in other components of the history that is eye-catching. So let's see if exam can help us make some progress.
Sure. So general exam, she was alert and oriented to time, place, people around, and self. She's a febrile, not pain, not jaundice, no lymphadenopathy, no lower limb edema, vital signs, elevated blood pressure 170/80, pulsed respiratory rate, temperature, and SATs were all normal. And the neuro exam, the higher centers was pretty normal. But on cranial nerve exam, she had of the twitching of the left eye and the left half of the face. The mouth was deviated. Oh, sorry. Yeah, the mouth was deviated to the left and was worsening with the twitching. She had an intact. Oh, something is not making sense here. Can you see the slides?
Oh, the slides have disappeared. You stop sharing.
Yeah, I think there is a video there. Okay. So I should reshare them, eh?
Yeah, yeah. Share your screen.
Yeah. Do you see them now?
Yes.
Okay. Yeah. So let me fast forward to the exam. Okay. Yeah. So I was presenting the cranial nerves. There was twitching of the left eye and the left half of the face. The mouth was deviated to the left and was worsening with the twitching. But the facial sensations were intact. Other cranial nerves were normal. And the rest of the neuro exam was normal. So this was supposed to be a video. I don't know why it's not playing. Does it play on your?
No, it's yes, I think you can press it there and
You see that?
yes.
So because of patient privacy, there's representative video, but it looked like this. Do you notice that?
Yeah, yeah. I can, although I do not appreciate much, but I think that was helpful.
So that's how it looked. And so yeah, the 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 rest of the exam was normal.
Okay. So that is for the physical exam. Now, so what we have here, I think I haven't made much progress. So what we were thinking of, what I was thinking of in the HPI, I think is the same thing that we are talking about here. That so what I am seeing, I am seeing here is basically this patient is not having. Uh, is I think this patient is maybe Joseph, just to clarify,
Mm.
when you're examining the facial nerve on the right, did you pick any abnormalities?
No, it was completely normal.
No abnormalities on the right.
Yes.
Okay. Yeah. So what we are thinking of is this patient is having, so the muscles on the left are contracting against the patient's will. That is what we are seeing. Joseph, your slides have disappeared.
Yeah.
So that's what I'm thinking, that the muscles on the left are contracting without the patient wanting them to contract. So that is a new problem that I have to solve. That we are dealing with. I'm not sure if that is the right term, but spasm of the muscles on the left side. So there is twitching. So twitching, that muscle twitch, so one way is to frame it as a movement disorder, and I think one of the things that I mentioned there is dystonia. So I haven't read dystonia in details. So I've read dystonia as part of hyperkinetic movement disorders. So dystonia being one of them. And then you have chorea, you have thetosis, you have balismus and hemibalismus. So those are hyperkinetic movement disorders. Now, causes of, if you are talking of dystonia, especially dystonia on the facial muscles or the axioskeleton in general, I only know a few causes of that, or something that can be associated with that. So, you can, dystonia is divided or is categorized based on which on the sites which are involved. So, for example, segmental dystonia. So, for example, I think with my limited knowledge of dystonia in detail, I would just say this patient is having facial dystonia because it's the facial muscles that are involved. So I believe it's a segment of it's a part of segmental dystonia. I think that is the only thing that I have for now. And now this dystonia, now what is causing the dystonia? Drugs are some of the things that are known to cause the hyperkinetic movement disorders in general. So, for example, when you talk of chorea, you talk of athetosis, or dyskinesia in general, maybe I should say, uh, dyskinesia. Yes, I think that that would be another term maybe, if I want not to confine myself and not commit. I think dyskinesia is another term that I could use. So a number of medications like especially psychotropic medications. If you talk of antipsychotics, we know that they are associated with tardive dyskinesia. So apart from the antipsychotics and many other psychotropic medications, any medications that you can think about that interfere with dopamine in a way. So, for example, metoclopramide, they also cause dyskinesia. Now, this patient, apart from those alternative remedies that she's using for the hypertension, which are not controlling the hypertension anyway, we have not heard about a history of use of any other medications, especially psychotropic medications, which would partly explain the picture that we are seeing. So, apart from that, we know when you talk of hyperkinetic movement disorders, infections, including infections in the basal nuclei, especially including TB and any other infections that you can think about, they can also cause these movement disorders. But then this patient review of systems was completely normal. And we hear that these symptoms are coming whenever the patient is stressed and they disappear whenever the patient is happy. So are we dealing with something idiopathic? Uh, I wouldn't, although maybe something psychogenic. I think this is too dramatic for something psychogenic. So maybe I am not aware of any psychogenic thing that can cause this. So I think I have a poverty of differentials. I'm thinking that we are dealing with a dyskinesia slash dystonia, but then what exactly is causing it, I'm not exactly sure. I'm not sure if investigations will help me make any progress, but let's see them anyway.
Yeah, so the labs, there was nothing. Fuba picture, renal, liver, electrolytes, well within normal limits. They do in many neuro cases. And here we are.
Okay, so it's time for diagnosis.
Mm-hmm.
Now let me go back and see if I am missing anything. So we are dealing with a 65 years old female. Uh, this patient has a background of hypertension. We do not know for how long, but uh, she's using some home remedies for the hypertension, but the hypertension is not well controlled. As we saw, the systolic blood pressure of 170. The patient presented with mouth deviation, which started 8 years ago, but it seems the symptoms maybe became more apparent 2 months prior, when she noticed that there is also twitching on the left side of the face, so involving the eye, but it also progresses to involve the lower part of the left half of the face. And these symptoms seem to be coming whenever the patient is stressed or anxious, and they disappear when this patient is happy. Review of systems is unremarkable. Labs are all unremarkable. Now, what are we dealing with? So, just like I said, when we hear mouth deviation, we would intend to think, okay, maybe it's a stroke. A history of 8 years is not in keeping with a stroke. So we are dealing with something chronic here, and the right side of the face on exam seems to be untouched. So basically, we're talking of a problem on the left, and that is the muscles on the left are contracting. They are contracting against the patient's will. So what is going on? Is it a problem, for example, with the a problem with brain structures that are involved in the control of muscle movement? So basically, whenever you see something like that, you think about the basal nuclei. Um, so with the basal nuclei, what exactly could happen in the basal nuclei that would cause this? So I mean, yes, maybe theoretically speaking, you can have a stroke involving the basal nuclei, and then you end up with or anything vascular that involves the basal nuclei, and then you have uncontrolled movements on a side, which is controlled by those structures. So I am not even in a position to say this is the case, but theoretically, I think we should entertain that possibility. But apart from that, I think I've discussed some other things like infections. You can have infections involving the basal nuclei themselves, including tuberculosis, retroviral infections, and many others. But then, at least the patient's history was not directing us in that direction. So, apart from thinking about an issue with the basal nuclei, let's come to the nerve let's come to the nerve itself. If we are talking about a supranuclear lesion of the facial nerve, we will talk more about weakness rather than dystonia or dyskinesia of these muscles. So, I mean, any lesion to do with the facial nerve causing paralysis, I think that is not a possibility. So, what else? A problem with the neuromuscular junction, commonly we talk about weakness rather than involuntary movement or contraction of the muscle. So I'm thinking we are dealing with a muscle issue, and when I say a muscle issue, I'm not talking about a primary muscle disease, but then you are talking about the you are talking about the action potential in the muscle. So something has to be wrong somewhere. So a nerve is firing, or the normal inhibition that we see in the muscles is not present. So those are the theories that I have. But I think if I am to just mention one thing, I'm thinking we are dealing with dyskinesia slash dystonia. What is the cause of this? I think I've failed to find that out. Yeah, so that's what I have. Just looking forward to learning from you, Joseph.
Yeah, thank you very much. That was clinical reasoning 101. doesn't matter, the diagnosis will be okay, right or wrong. So I I've seen a case of dystonia. I believe you have seen one also. And when I saw this patient, I also thought of dystonia. But I tend to read the cases that I see. I was trying to look at the medication that I could give this patient, and I wondered, why is it 8 years? She was working in a hospital as a nurse, and that hospital has neurologists. And they told her that it's something to deal with the fascial nerve. So I said, okay, these neurologists have to be right. I had to dig and read. When I read about dystonia, if this was a dystonia, it has to be focal dystonia, not generalized. And the focal dystonia, as David, you're mentioning here, fascial dystonia. But the most common focal dystonia is cervical. And if it is fascial, maybe it is a blepharospasm, as you're saying, involving just the oculars. And I read something that threw me off. Say this is not can't be right. It said dystonia has to be bilateral, and then it will disappear when someone sleeps, which were not the case in these patients. And what is called facial dystonia usually is not just the face. You can see the face and the neck, or you can see what is called oropharyngeal or something, like the face. I had a case when I was a resident, the face and the muscles of swallowing. When it came, this patient started like aspirating. And then you go to the differential diagnosis. I saw something which say, okay, it has to be the case, and that was hemifascial spasm, and everything in this patient made sense. And I looked at the videos online, like the one I'm showing you there, and that's how the patient looked like. The only thing, as you see in teaching points, it can be like tonic or clonic. So if it is tonic, like this patient, there is tone to that muscle. That's why David is saying the side affected has to be the left, because there is tone of the muscle causing mouth deviation. And the patient, they don't come with a complaint of twitching; they come with a complaining of mouth deviation when it's a tonic like this. I saw one case of like last year, one case of hemifascial spasm, but it was a new presentation. Like patient came in today, it started in the morning, and then they were like after 1 hour they came to me. It was clonic. It was clonic with that patient. It's just twitching, 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 and they remain normal. Twitching, twitching, they remain normal. But when I saw this, I didn't realize that there can be a presentation like this. So it was a pretty nice case to learn, and I called the neurology. So I wondered, first of all, why is it 8 years? This patient was working at a big hospital, and they haven't been treated. But they are told there's no treatment in the country, and they had to go to like abroad, and they couldn't. They didn't have the money. So I called neurology because 8 years has passed, and one neurologist at Loganzira said, because the treatment, as you see, the mainstay is botulinum injection, and neurologists say they do that. And I was so happy to also learn that as we are advancing just 8 years, we already have the super specialists, and they are doing that thing, and it's no more expensive. So I'm sending this patient like next week to get botulinum toxin. So this was the case for today, and we have some teaching points here. So the epidemiology, female are more affected like 2 times than the male. The average age of onset, it can occur in any age, but the average age of onset is 45 to 52. The way to present, twitching of the facial nerve, twitching of the facial nerve muscles, as we saw in this case. So the twitching will start in the periorbital muscle. So when I went back to ask this patient, like how the twitching starts, she told me this story. So it starts with the eye and spreads to involve these. Like she said, she used the word, it infects the other muscles. So if you see this complete 100% hemifascial spasm, so it will start in the periorbital muscles and then spread to epistachial fascial muscles over months to years. And like this, like it was 2 months. But again, if it starts twitching on a particular day, it also starts with the eye and spread to the muscles. 95% is unilateral, and if it happens to be bilateral, it is never synchronous. One side is affected this time, the next time the other side is affected. So it can be clonic or tonic, I've seen tonic and this, I've seen chronic and this was tonic, and it threw me off to think maybe it is not a hemifacial spasm. So yes, it is worsened by stress, anxiety, fatigue, and facial movement. So this worsened by stress and whatever, and getting better with a good mood also is present in dystonia. So when I hear this story in the first, when I was taking his history in the first when I saw the patient initially, I thought it is dystonia also because I knew this. But again, it's also present even if hemifacial spasm. So the etiology usually is idiopathic. Some patient might tell you they had a history of Bell's palsy in the past, and or a compression of the facial nerve root, usually by a vessel. I didn't want to send this patient an MRI because there will be no change of anything I'm going to do. And 8 years, there is nothing like a scary that will be compressing her nerve. So that's why I didn't do an MRI to see the compression. Treatment, botulinum toxin injection is the mainstay. If you don't have that, carbamazepine. Initially, I didn't know if we have it. I put this patient on carbamazepine. Unfortunately, they didn't work. 1 week on medication, no change. Also, you can have baclofen, anticholinergics, clonazepam. But if you are in a place where you can get botulinum toxin, you have to do that. They'll be going there. I think I will learn from the neurologist now, like the frequency, how they do it, and even if maybe someone like me can train and maybe I can provide it because just injecting as we inject the knees of patient with osteoarthritis probably. Yeah, so David, that was it. That was a short and sweet case of today. Do you have any reflections?
Thank you, Joseph. Um, yes, so this was quite a learning experience because at least as you are presenting first, I did not know at least if I would come this close to the diagnosis because everything that I had initially, there was no familiar pattern that I could recognize in the patient's presentation. So I think that's what reminds me that reading, just reading again and again, that helps because at least whenever you have whenever you have the basic sciences right, sometimes you can reason,
Yeah,
although very slowly through a case, but at least come close to something.
sure.
So yeah, I think that was a lot of learning because with especially with neurology cases, we do localization in a systematic way. Now, for this particular case, it would be very hard to do localization systematically uh, rather than just identifying the patterns that, okay, so what we are seeing here, because otherwise I think it could you take it could take you down the wrong route, thinking, okay, so we are having facial nerve palsy on the right, and then so someone would say we are dealing with Bell's palsy of the right, for example, and ignore the twitching on the left. So I think there was a number of clues that were pointing in the direction that we're dealing with something on the left. And I kept mentioning that there is spasm of the muscles on the left, and then a diagnosis of hemifacial spasm does not come to mind. Yeah, so thank you very much for the case. I think I have something to go and learn, and also to just to read more on disorders of the facial nerve and the presentation that could mimic what you presented today. So thank you very much for the case.
Yeah, thank you. So, do you have anything from the floor? Want to hear from you? Like any question in addition? Um, yes, Joseph Kazaura.
Yeah, good evening, everyone.
Good evening, Joseph Kazaura. How are you?
I'm very good. Thank you for a very nice case. I think neurology is more tricky. So I would just love to ask David if he can give us little elaborations why he thought of ignoring the Bell's pulse with respect to the twitching. If you have a lesion, a Bell's pulse on the right side, is it not possible to have twitching on the left? I think I've missed some points with regard to dystonia diagnosis. Thank you.
Okay, thank you, Joseph. So it's I didn't recognize any particular pattern here, but what made me know that we probably have a problem on the right side. It's when I heard it's when I heard Joseph. Can you mute your microphone a little bit because there's some noise coming out. Yeah. So what made me know the possibility of a facial nerve palsy on the right is because I saw that there are some other associated symptoms, and these other symptoms are coming from the left. So, for example, if we were having a, a stroke, for example, involving the right facial nerve, or if we had Bell's palsy or any lesion of the right facial nerve, yes, we would expect the mouth to be deviated to the left because the right is the weak one. So the mouth is basically pulled to the stronger side. That is what we would expect.
Mm.
But then because the left side would be the normal side, then we do not expect other muscles on that side to be contracting. Like for example, you have blepharospasm, but on the left, which presumably would be the normal side. So that is what made me think that most likely we are not dealing with weakness on the right, but rather we are dealing with muscle spasms on the left. So that is what made me think that most likely the pathology is on the left rather than the right.
Yeah.
Okay, thank you, David. I got the point.
Yeah, thank you very much. I see, Tom, you have your hand up. Please welcome.
Yeah, thank you for a nice discussion. I have a question concerning treatment. The Botox, will that be curative or symptom reliever? But regarding prognosis, she has been having the presentation for almost 8 years. Will that make a difference if she had received the treatment back then and if she received the treatment now? Thank you.
Yeah. Thank you very much, Tom. So, my understanding is the Botox you'll be receiving in after some time. Like she goes, I don't know if it's 1 month or 3 months. But when she was told to go to India back then, she said she had to go every 3 months because there was no botulinum toxin in the country. So it's a lifelong disease. She will be receiving botulinum toxin. It's like to numb the facial nerve so that it shouldn't be pulling the muscles. So it wouldn't make it would make no sense, no difference if she was treated then back then or now. The disease is just there.
Okay, thank you. Thank you very much.
Karibu. Yeah. So thank you for that of you that contributed. Thank you, David, for discussing. I think we should close, and next week we'll be here again for another case. Good night.
Good night, everyone.
Night.